This is Dr. Caudill Miller, or Dr. Miller's Guide to Neurology. We've been talking about headaches, and today we're going to talk about the biochemical mechanism, what happens during a migraine or a headache. We talked first about, vascular mechanism, constriction, vasodilatation, then vasodilatation larger than normal. Then you have this release of chemicals. This is the biochemical mechanism. Then this electrical tsunami or tidal wave of electricity across the brain. So we're going to talk about the middle pathway. Because when we treat migraine and tension headaches, we pick drugs out of any one of these three pathways, and then the fourth pathway, the trigeminal activation system, which we'll talk about later. So the biochemical mechanism, we use it in migraine and tension headaches. And it's very common to see an increase in substance P. Substance P is the main pain neurotransmitter. Some people think it may be the only one. There's some small ones they see on electron microscopy. It's found, but they're not sure what they are. It's found in the periaqueductal gray of the midbrain. It's interesting, it's called substance P. The P is not for pain, but that's what I think of it as, substance P, the main pain receptor. So the first classes we've used for 50 years, the tricyclic antidepressants. Elavil we've used forever. We don't use Elavil as much as we used to. Pamelor is my favorite one, then dizipramine. We also use some of the other antidepressants, Cymbalta, Effexor, Wellbutrin. SSRIs don't work for headaches unless there's accompanying depression. And what these drugs do, they do it to a different degree. They increase serotonin or norepinephrine. Some of them increase serotonin more, some of them increase norepinephrine more. Some of them, like Cymbalta, theoretically increase serotonin and norepinephrine equally. So Pamelor is probably my favorite one in this class. We always start at baby doses. There's no hurry, so 10 milligrams at bedtime and increase gradually. There'll be a separate video on Pamelor, but we talk about the side effects. About 30% of people, particularly women, gain weight. You'll never know really, because so many people in America gain weight, if this is the Pamelor. We always warn people on their headache calendar to weigh once a week and follow this closely. It can make you drowsy. We use that for a benefit. Someone that doesn't sleep, maybe someone who's thin and doesn't sleep, use Pamelor. It can be, the side effect can be a good sleeping pill. We rarely see this, but I've seen it multiple times, urinary retention in men that have prostate issues, particularly BPH, so it's something we need to watch. Elavil or amitriptyline is the other tricyclic. Don't use as much, but like a little elderly 90-year-old lady who can't sleep, Elavil is a good choice. Cymbalta is another antidepressant that increases serotonin and norepinephrine. This is a newer class of drugs, and I really thought there'd be a bunch of drugs in this class come out because theoretically increasing serotonin and norepinephrine can work both for anxiety, depression, and pain. Use 30 milligrams at bedtime. Start a very low dose, 30 milligrams in the morning, with food. It's going to be a little bit of an upper. If it makes people drowsy, have them taken the bedtime, but sometimes people like the fact it's a little bit of a feel-good kind of medicine. And then go to 60 milligrams. Main side effect is nausea, so take it with food. Cymbalta is one of the antidepressants that can rarely cause serotonin syndrome. My theory is we're trying to increase serotonin and norepinephrine where these patients already have normal or high serotonin. You give them Cymbalta, they start getting tremulous, anxious, sweaty. If you put someone on Cymbalta, they start getting anxious pretty quick. Just stop it, because severe serotonin syndrome is, though rare, it can be life-threatening. Effexor is another antidepressant, very, very safe. Start at low doses, 37.5 milligrams. You really need up to 225 to really maximally affect pain pathways. Most people can't take that much. But we found that, 37.5 to 75 generally works. 150, works for headaches. Very, very safe. Once again, has the same side effects of all the antidepressants, make you a little drowsy, sometimes constipated or nausea. We don't see that much. But if it causes anxiety, it's another one of those drugs you have to watch. They may have normal serotonin. You push it too much, you get anxious. It can rarely cause a serotonin syndrome. Wellbutrin's the last one that blocks norepinephrine and dopamine, so it's a little bit different mechanism of action. It's another one to try. So it can actually cause headaches. I've not seen that. Nausea, constipation. The negative about Wellbutrin, can't use it in people that have seizures or epilepsy because it can precipitate a seizure, and people have seizures on Wellbutrin, they can never take it again. So the one thing I like here, if we're focusing on this class, you've got a lot of different choices, so we're talking Pamelor, Elavil, dizipramine, Cymbalta, Effexor, Wellbutrin, a lot of different things to try. So if they have side effects from one, you can try another. So when would I use the drugs in this class? If someone has headaches and they have depression, if someone has headaches, they have anxiety, someone has headaches and they can't sleep, try to match the drug to the patient profile. So that's the electrical mechanism of headaches. So we're going to talk more about headaches later and more about all the different clinical things we treat in a private practice in neurology. So like my channel, subscribe, make any comments, and more later.